own facilities under a 2024 rule by August 9th, 2026. Less than 2 months from today, state and local government entities that use examination tables and weight scales must have at least one accessible example of each that meets enforceable federal standards. That deadline applies directly to city-operated health facilities, including health and hospitals and DOHMH's sexual health clinics. And we cannot talk about reproductive access for people with disabilities without addressing the history of reproductive control exercised over them. From a documented history of coerced sterilization to present-day questions about guardianship, informed consent, and decision-making authority, people with disabilities continue to experience higher rates of sterilization than people without. And pending state legislation S3357A1582 would bar providers from presuming that a person with a disability lacks the capacity to consent. Autonomy is part of access. So today we are asking straightforward questions. With the August 9th federal deadline almost here, are the city's own health facilities equipped with accessible diagnostic equipment? And where are the remaining gaps? DOHMH, H&H, and MOPD have acknowledged in their own accessibility planning barriers around inaccessible exam space, equipment, and communication. Are these agencies coordinating to close them, and on what timeline? What disability-specific clinical training are providers in the city's reproductive and sexual health settings actually receiving, and how is it being measured? Are the sexual health clinics and the abortion access hub reaching New Yorkers with intellectual, developmental, sensory, and psychiatric disabilities? As federal Medicaid cuts move through the safety net system, these New Yorkers depend on what is the city's plan to protect their access to reproductive and sexual health care. We are also hearing legislation today, and we look forward to the administration's and the public's feedback on it. Intro number 200, sponsored by Councilmember Jennifer Gutierrez, in relation to creating resources for doulas. Intro 211, sponsored by myself, in relation to requiring the Department of Health and Mental Hygiene to provide information regarding fertility treatment, including insurance coverage of fertility treatment. Intro 840, sponsored by Councilmember Kayla Santos-Oso, in relation to requiring health insurance coverage for pre-implementation testing for city employees. Intro 941, sponsored by Councilmember Linda Lee, in relation to requiring the Department of Health and Mental Hygiene to develop and offer resources, clinical guidance, and training on disability and accessibility in healthcare settings. And Intro 953, sponsored by Deputy Speaker Dr. Natasha Williams, in relation to requiring the Department of Health and Mental Hygiene to make medication abortion available at no cost to a patient at all of its sexual health clinics. We are also considering proposed resolution 89A, sponsored by Councilmember Gutierrez, calling on the New York State Assembly to pass A9175 and the governor to sign S2058 A9175, legislation to require each institution within the State University of New York and the City University of New York to have at least one vending machine making emergency contraception available for purchase. Proposed Reso 108A, sponsored by Councilmember Frank Morano, calling on the New York State Legislature to pass and the governor to sign S5262 A3051, legislation creating a refundable tax credit for up to 3 cycles of in vitro fertilization not covered by insurance. And Reso 447, sponsored by Councilmember Santos-Oso, calling on the New York State Legislature to introduce and pass and the governor to sign legislation to ensure insurance companies cover the cost of pre-implantation genetic testing for aneuploidies. It's a medical term that I'll need to learn how to say. I will now read Health Committee Chair Lynn Shulman's opening statement. Good morning. I'm Councilmember Lynn Schulman, Chair of the New York City Council's Committee on Health. I want to thank you all for being here today at our oversight hearing on access to reproductive health care for New Yorkers with disabilities. I apologize that I could not be here in person, and I want to thank Chair Hanif for holding this important oversight hearing and for reading the statement on my behalf. New York City is a beacon in the U.S. and across the globe for providing comprehensive access to high-quality reproductive health care. As the federal government and other states try to roll back the right to bodily autonomy and restrict access to comprehensive and inclusive care, our city has taken a stand to ensure that anyone, no matter who they are, where they come from, and how much they can afford, can access high-quality and non-judgmental care for the full range of reproductive health services they may need. DOHMH is instrumental in this area, providing information and resources for those seeking care, and directly providing such care at little to no cost at the department's 6 sexual health clinics located around the city. These clinics provide essential services, including medical evaluations, STI testing and treatment, PrEP consultations, pregnancy tests, emergency contraception, and at some locations, medication abortion. Today's oversight hearing focuses on meaningful access to care, particularly for the disability community. Pursuant to Local Law 12 of 2023, DOHMH developed a 5-year accessibility plan to improve accessibility to its facilities and services across 5 areas: physical access, digital access, effective communication, programmatic access, and workplace inclusion. The plan identifies ongoing accessibility challenges across DOHMH facilities, including inaccessible examination spaces, narrow doorways, insufficient accessible medical equipment, inadequate signage, and barriers associated with aging infrastructure that predates the Americans with Disabilities Act. And as we look to combat rampant misinformation and disinformation in the public health space, we must also ensure that DOHMH's messaging is reaching as many New Yorkers as possible. I look forward to a robust discussion of how DOHMH plans to improve accessibility across its resources and services, including at its sexual health clinics, and how it is more broadly directing resources toward realizing the accessibility goals laid out in the 5-year plan. I also look forward to receiving feedback on the legislation being considered today, the majority of which is in the Health Committee. These include proposals to reduce the costs of IVF process, expand access to medication abortion and emergency contraception, improve the citywide doula program, and educate New Yorkers about fertility treatment and insurance coverage options. All of these bills share the common goal of strengthening and expanding access to the full suite of reproductive and family planning services for all, regardless of ability, income, or gender, and to help build a New York City where families are healthier and feel empowered to make informed decisions about their futures. As I often say at these hearings, healthcare is a human right, but a right is only as meaningful as the ability to act on that right. While I am proud that New York City seeks to protect the rights and dignity of all people to make their own decisions about their healthcare, we must keep fighting to eliminate barriers and to ensure meaningful access to that care. I will conclude by thanking Chair Hanif again for holding this hearing and by thanking the representatives from DOHMH and the administration for being here today. Now I will pass it to Chair Narcisse for her opening statement.
Good morning and thank you, Chair. I'm Council Member Ms. Mercedes Narcisse. I'm a Black woman wearing a reddish hair and a green dress. I'm in beige and green flooring dress. I'm happy to be here this morning and talking about something that's very important to all of us and folks that really need our assistance in New York City to improve their lives. So whenever I can, I will be present. Today I was not supposed to be here, but when I have the opportunity, I'm here with you. Thank you to Chair Hanif for convening this important oversight hearing on reproductive health care for New Yorkers with disabilities and for inviting me and Chair Schulman and to talk about this issue. Before I get deep in the issue, I know you all are New Yorkers. We are very proud of the team. Yes, Knicks did it for us over 50 years. So as New Yorkers, I want to bring that up. Congratulations to the team and all the supporting fans that have been dying to see this moment. So I'm very happy. I had to add that in. Access to reproductive health care remains a critical issue for New Yorkers with disabilities, who often face persistent barriers such as inaccessibility, medical equipment. And I know how important that is as a registered nurse and as well as a provider for healthcare medical equipment for many decades. Limited communication supports is very important. And a lack of disability, we need to have our disabled population to feel part of this important world. And I'm so happy. We have to make sure that every support that we can give, we give it and support and inform our population. That is very important to our community. New York City Health and Hospital, as a city public health system, play a central role in addressing these challenges by providing comprehensive reproductive and sexual health services across its hospital. Gotham Health Clinics and community health centers. These services include contraception and family planning, pregnancy-related care, abortion counseling and services, and HIV prevention and treatment, all provided regardless of a patient's ability to pay. Over the years, H&H has made great progress in improving accessibility, reporting ADA compliance across its facilities, and ongoing efforts to bring newly acquired sites into full compliance. Several Gotham Health clinics are fully accessible and offer additional accommodation for patients who are blind, deaf, or hard of hearing, alongside investment in infrastructure, assistive technologies, and staff training. These initiatives position H&H as a key provider at the intersection of disability access and reproductive health care in New York City. However, despite these advances, many individuals with disabilities continue to face barriers in finding adequate reproductive and sexual health care due to the limited availability of access equipment and specialized disability-specific care from providers who have received comprehensive training on best practices for training patients with disabilities. These ongoing barriers underscore the need for more targeted disability-informed approaches within reproductive health services so that all New Yorkers can receive the best care possible. Before I conclude, I would like to thank the committee staff for their work in preparing today's hearing. While unfortunately, I have to tell you, I cannot stay long, but I believe the Chair Hanif will do an amazing job and make sure that we're addressing all the issues that need to be addressed. And with your support, we'll do that. I'm committed to this. This is not just now. I'm committed for equitable access to reproductive health care for New Yorkers with disabilities. It remains a priority for me. And like I said, as a registered nurse, I appreciate every aspect that we can do while I'm here to address the needs that I have seen over decades. I look forward to reviewing the hearing and debriefing with my committee staff to further examine these issues and identify ways to improve everyone's lives in New York City. We're part of the city. So thank you, Chair.
Thank you, Chair. And now I'll pass it to Councilmember Morano for his opening statement.
Thank you, Chair Hanif. Thank you, Chair Narcisse, and all my colleagues on the committees on disabilities, hospitals, and health for hearing Resolution 108 today. At its core, this resolution is about something very simple: whether the opportunity to become a parent should depend on the size of your bank account. And for millions of Americans, infertility isn't some abstract policy issue. It's a medical condition. It's a source of stress. It's a source of heartbreak, uncertainty, disappointment, etc. And for many, in vitro fertilization offers hope. It offers a chance to build the family they've dreamed about for years. But the fact is, hope, at least in the form of IVF, is very expensive. A single cycle of IVF can cost $15,000 to $20,000. For many families, one cycle isn't enough. Some require 2, 3, even more attempts before they're successful. By the time medications, testing, and other associated costs are included, families can find themselves spending tens of thousands of dollars. I've spoken with New Yorkers who've emptied their savings accounts, taken on second jobs, accumulated debt, delayed buying a home, or postponed other major life decisions simply to pursue the possibility of having a child. And many never get that opportunity at all. So the reality is that access to fertility treatment often depends on where you work, what insurance plan you have, or how much money you have available. And that's especially true for working and middle-class families, for LGBTQ New Yorkers, for cancer survivors pursuing fertility preservation, and for countless others trying to navigate an already difficult journey. This resolution supports legislation pending in Albany that would establish a refundable tax credit covering up to 75% of eligible out-of-pocket IVF expenses for up to 3 cycles not covered by insurance. That word, refundable, is important. This isn't a benefit reserved for the wealthy. This is designed to provide meaningful relief to the families who need it most. I'm proud that this resolution has attracted support from members across the ideological spectrum in all 5 boroughs. And looking at the sponsor list, you'll find conservatives, progressives, moderates, Democrats, and Republicans. That's because the desire to have a child isn't partisan in the least. The desire to build a family isn't partisan. And this is about recognizing that family formation remains one of the most important goals many people will ever pursue, and that government shouldn't stand idly by while financial barriers place that goal out of reach. So today, the committee has an opportunity to send a message to Albany that New York should do more to support people who want to become parents. So I want to thank all the co-sponsors, including the folks behind me, the committee staff, and everyone who shared their personal stories with us. These stories are the reason this resolution matters so much. So I respectfully urge the committee to support Resolution 108A and help more New Yorkers realize the dream of building a family. Thank you.
Thank you, Councilmember. Now I will be reading Deputy Speaker Natasha Williams's statement on her bill. Thank you, Chairs Shulman, Narcisse, and Hanif for convening today's oversight hearing on access to reproductive health care for New Yorkers with disabilities, and for hearing Intro 953. I regret that I am unable to be present today, but I appreciate the opportunity to submit the statement in support of my bill. Intro 953 would require the New York City Department of Health and Mental Hygiene to make medication abortion available at no cost at all of its sexual health clinics. While current law requires this medication to be available at certain clinics, this bill would ensure consistent access across all DOHMH sexual health clinic locations. This bill is about access, equity, and consistency in care. Reproductive health care, including abortion care, is essential health care. At a time when reproductive rights continue to be challenged across the country, New York City must remain committed to protecting and expanding access to care. Even small barriers, such as confusion about available services, transportation challenges, or delays in care, can have serious consequences, especially when care is time-sensitive. No one should walk into a city-operated sexual health clinic unsure whether they will be able to access the care they need. Intro 953 helps close that gap. It ensures that regardless of which DOHMH sexual health clinic a patient visits, they can expect the same standard of care. Every New Yorker deserves access to safe, timely, and affordable reproductive health care. This legislation helps move us closer to that goal. Reproductive health care is not optional care for New Yorkers with disabilities. Equitable access to it touches bodily autonomy, equal treatment under the law, and the ability to participate fully in their own lives. We will not get this right by treating it as a clinical problem alone. We have to be honest about the physical barriers that remain, the training gaps that persist, the federal threats bearing down on the safety net, and the gap between what is promised and what is delivered. Thank you to the administration for being here today, and to the disability advocates, service providers, healthcare workers, and members of the public who have traveled to testify or submitted written testimony. Your presence here is an act of self-advocacy, and we do not take it for granted. Thank you to all of the staff who made today's hearing possible, including Disabilities Committee staff, Senior Legislative Counsel Sarah Sucher, and Senior Legislative Policy Analyst Chloe Rivera, Matt, my Chief of Staff, and Anisha, our Legislative Fellow. I also want to recognize the council members joining us in person and remotely. Council members De La Rosa, Wilson, Morano, Marte, Epstein, Areola, Brooks Powers, Aldebal, and Nurse. I will now pass the mic to the committee counsel to administer the oath to members of the administration prior to their testimony.
Will you please raise your right hand and respond verbally with "I do"? Do you affirm to tell the truth, the whole truth, and nothing but the truth before these committees, and to respond honestly to council member questions? All right, you may begin your statement when ready.
Good morning, Chair Hanif, Chair Narcisse, and Chair Schulman, and the members of the committee. My name is Nisha Agarwal. I'm the Commissioner of the Mayor's Office for People with Disabilities. I have short black hair and brown skin, and I'm wearing black top and slacks. I have aphasia, and I may have my handy cane by my side. Thank you for scheduling this meeting on reproductive health care for women with disabilities. This impacts me professionally and personally. New York City has made significant investments in reproductive health care, and MOPD values this incredible progress. Yet, women with disabilities continue to face barriers on these services. That may include inaccessible facilities and equipment in the healthcare setting, challenges on accessible communications, and segregated healthcare. First, I will share some of the laws that are meant to assist women with disabilities. In 2024, the U.S. Department of Health and Human Services updated two rules for state and local healthcare settings who provide federal financial assistance with the goal to improve healthcare settings and civil rights protections for people with disabilities. For example, the federal rule requires healthcare settings to provide appropriate auxiliary aids and qualified interpreters, real-time caption, qualified readers, audio recordings, and Braille materials, among other supports. In addition, the rules also ask a timeline for states and localities to provide medical diagnostic equipment, such as exam tables, mammogram equipment, weight scales, and radiology equipment that will assist people with disabilities, especially women. These changes will happen in August. The rules are intent to ensure that all people receive equitable health care compared to others. However, many healthcare settings have yet to reach this standard of care. In practice, women with disabilities face barriers in reproductive health outcomes. For example, research by a distinguished women professor with disabilities reported that 81% of women aged 18 years or older without disabilities received cervical screening within 3 years, compared to only 67% of women with chronic mobility limitations. In another study on reproductive health by the same author, women with disabilities were 70% less likely to other women to be asked about contraception during routine office visits, because the physicians erroneously assumed that they were not sexually active. Accessible equipment and communications alone won't ensure that women with disabilities have equitable health care. Anti-bias training from the health community is critical as well. I'd like to now share how the Mayor's Office for People with Disabilities is supporting and leading this effort in concert with women with disabilities. Last Friday, MOPD and the Deputy Mayor of Health and Human Services, Helen Arteaga, visited the NYU Initiative for Women with Disabilities in Manhattan. This is a healthcare setting focused primarily on gynecological care and wellness services for women with disabilities. And I went to this institution for many years after my stroke. We toured around the hospital setting where they had exam tables, mammography equipment, and weight scales designed for women with disabilities. And the director shared that it may take women with disabilities more time to get into their robes, into the exam table, and out and go through the mammogram procedure. But in the end, it was better for patients and for the hospitals. Women received good health care, and the hospital reduced the misdiagnosis for women with disabilities. Equally compelling was the internal process. In procurement, for example, the hospital has questions on disabilities for potential vendors to ensure accessibility. And the hospital is now in the process of adding data fields for people with disabilities alongside race, gender, etc. The goal is on people-centered design, but also helps the bottom line. If you do it well, people will come. We also are planning a roundtable with women with disabilities on healthcare, with a portion focusing on the problems that women face in the healthcare settings, and a larger discussion on solutions with hospitals, clinics, and providers to ensure that health institutions broadly are more inclusive and accessible. And we would love if you, Chair Hanif, could join the roundtable as well. Finally, I'll end with some personal reflections. It was a long road to recovery for me, but it was through my family, friends, doctors, therapists, co-workers, and an immense community that I can now walk and talk and argue and dance. And I am very lucky for having that. But this is also my privilege. As a commissioner, I got access to every doctor, every therapist, people at the highest level to help me recover. But as I talked to people, women, with cancer and stroke, the difference was palpable. The place that you live, the employment that you had, the hospital that you went to, the color of your skin, all played a factor in how well you recovered and thrived. In the end, it was the access that you have, not the medical condition, that mattered. Our goal is to change that outcome. Thank you so much for the opportunity to speak today. I deeply appreciate the Council's attention to this important issue, and I will look forward to answering your questions and continuing to work together.
Go for it.
Good morning. Good morning, Chair Sharman, Chair Narcisse, Chair Hanif, and members of the committee. I'm Joaquin Aracena. I'm the Assistant Commissioner for the Bureau of Public Health Clinics at the New York City Department of Health and Mental Hygiene. I sit here, Hispanic male, short hair, blue suit, pink and blue polka dot tie, pink and blue polka dot pocket square, and joined today with me is Amanda Alvarado, the Health Department Director of Accessibility and Disability Services Facilitator. She sits here in a pink suit, white shirt, short hair, and also wears glasses. Thank you for the opportunity to testify today on access to reproductive health care for New Yorkers with disability. The New York City Health Department is a leader in the country in offering cutting-edge sexual and reproductive health care. Our 6 sexual health clinics offers a suite of low to no cost sexual and reproductive health services to people ages 12 and older, regardless of ability, immigration status, or insurance status. To expand access to care, we also offer telemedicine services through our sexual health clinics hotline. Our sexual health services include testing and treatment for HIV, chlamydia, gonorrhea, syphilis, and Mpox, vaccination for HPV, hepatitis A and B, meningitis, and Mpox, and preventative care like HIV pre- and post-exposure prophylaxis. Our reproductive health services encompasses contraception, including emergency contraception and medication abortion. Most of our services are available without an appointment. We're always working to improve and expand our clinic services to better meet our patients' needs, recognizing our clinics are a gateway to healthcare for many New Yorkers. We also offer linkage to healthcare providers and other resources, including through on-site licensed social workers. Our sexual health clinics are the safety net of the safety net, reaching many people who have been historically disenfranchised by the healthcare system. Of patients seen in 2025, over half reside in Tree neighborhoods. Over 2/3 reported being uninsured, and nearly 3/4 were person of color. The department is unwavering in our commitment to providing low to no cost services and creating safe, affirming spaces for all New Yorkers. Everyone deserves access to compassionate care without barriers. Over the past several years, the New York City Health Department has made significant progress towards improving accessibility of our services to the public, as well as the internal reform to make the agency more accessible to staff members with disability. While we have much to accomplish, we are proud to be leading these efforts, which include evaluating signage at health department facilities and implementing accessible signage, developing and implementing disability justice trainings, and renovating buildings for enhanced accessibility. Our sexual health clinics buildings are physically accessible, and we are making them compliant with the ADA Act as we renovate and retrofit spaces. Turning to the legislation under consideration today, Introduction 200 would require us to develop a doula Bill of Rights, as well as the submission form to receive feedback from doulas. The bill would also establish a doula advisory council to study the work of doulas in the city. We support the intent of this legislation and share the council's goals. We are still assessing the implementation needed for this legislation and its operational impact. We look forward to continuing the conversation. Introduction 211 will require us to conduct a public education and outreach campaign on fertility treatment, including insurance coverage. The New York City Health Department is committed to ensuring that New Yorkers have access to accurate, timely information and services that support their sexual and reproductive health. While the department plays an important role in connecting New Yorkers to reproductive care, services are primarily delivered through external healthcare providers, health systems, and insurance plans. The department does not provide fertility services nor have expertise to provide information to the public. Additionally, insurance coverage and eligibility requirements can vary significantly across Medicaid managed care plans and private insurers, creating challenges in providing information to the public. We are happy to discuss this further after the hearing. Next, Pre-Introduction 2060 would require us to create a disability, competency, and accessibility training program, as well as educational resources for healthcare providers and patients regarding disability-related healthcare rights and resources. The department supports the intent of this legislation. However, we have no oversight role of healthcare providers in New York City, as they are regulated by the state. Further, the development of comprehensive evidence-informed training, curriculum, stakeholders, and engagement processes. Ongoing program administrations would require subject matter experts that we do not have. Lastly, Pre-Introduction 2088 would require us to provide medication abortion at no cost to patients at all of our sexual health clinics. We support expanding access to medication abortion for New Yorkers alongside our full suite of sexual and reproductive health services. We do have operational concerns that we hope to discuss with the council, including hiring challenges and
Health and Hospitals, System Chief of Obstetrics and Gynecology, wearing a blue suit and orange shirt. At New York City Health and Hospitals, also known as H&H or referred to as the System, our commitment is to excellence in healthcare. Built on a foundation of social and racial equity, H&H is led by standards known as ICARE, which stands for integrity, compassion, accountability, respect, and excellence. With this ethos as a guidepost, clinical and non-clinical staff strive to ensure that all New Yorkers who walk through our system's doors are treated with dignity throughout their care experience. No exceptions. Historically, people with disabilities have faced elevated stigma and bias across healthcare systems, including sexual and reproductive health. H&H is a leader in providing culturally responsive healthcare services and continuously strives to remove barriers for special populations experiencing a disproportionate burden of illness. This commitment also extends to sexual and reproductive health conditions that have consistently faced delays in diagnosis and treatment, such as endometriosis and chronic pelvic pain. H&H offers multitudes of diagnostic tools, medical therapies, and surgical procedures, as well as treatment plans to address all patients' healthcare concerns. Patients who seek sexual and reproductive health care are met with a robust team of clinical staff, including specialized physicians, surgeons, nurses, mental health providers, and social workers to meet patients where they are in all of their sexual and reproductive, or in their sexual and reproductive healthcare journey. H&H's women's health clinical programs are designed to prioritize listening, validate the patient experience, and provide equitable, comprehensive, multidisciplinary care that is coordinated across the care continuum. H&H has a comprehensive obstetrics and gynecology program that provides evidence-based, compassionate care to help, or abortion care. H&H staff provide on troubleshooting everyday clinical issues to develop system-wide standards and guidance, allowing for challenges noted at one facility to be brought to the group to proactively address them across the system. In its ongoing efforts to find innovative ways to reduce barriers to care, H&H became the first public health system in the nation to launch telehealth abortion care through Virtual Express Care in October 2023. The Virtual Express Care Abortion Access, also known as VECAA, program provides patients the opportunity to access reproductive health care where and when it best meets their needs, and receive medication abortion at 2,300 people beyond the clinical services provided by the H&H staff. In addition to the programs described, H&H prioritizes accessibility across its facilities and services to ensure individuals of all abilities can access care. Across the system, facilities are ADA compliant and equipped with height-adjustable examination tables to make transfers easier for patients with mobility limitations. Facilities are also designed with accessibility in mind, including door frames and hallways that have been constructed to accommodate individuals who use wheelchairs and other mobility devices. To strengthen staff capacity to serve patients with disabilities, H&H has partnered with the Helen Keller National Center and the Lighthouse Guild to conduct blind and low vision simulation training to help staff better support patients navigating facilities. To further support all patients seeking reproductive health care, H&H's reproductive health navigators assist patients who may need extra support accessing services, including transportation, escorts after receiving anesthesia, and other forms of care coordination. The system also ensures that patients can access information and resources in their preferred format and language through the Accessible Format Directory. Through this directory, staff across H&H can provide patients consent forms in large print, Braille, and also audio files in English and other top 5 languages at their respective facilities. New York City Health and Hospitals remains committed to ensuring that all New Yorkers with disabilities seeking sexual and reproductive health care feel seen, heard, and respected during their visit to our facilities and system. Through ongoing innovation and a commitment to culturally competent care, we will continue to provide healthcare services that uphold the dignity and unique needs of every patient. Thank you again for the opportunity to testify today on this critical topic. I'm happy to answer any questions.
Thank you. We've been joined by Councilmembers Farias and Sanchez, and I want to pass it to Chair Narcisse for her questions.
Thank you, Chair. One of the things I want
And
to ask,
Councilmember Joseph.
one of the things I want to quickly ask, what are the top 5 languages that we're talking about that we provide care at H&H?
Yes. Our top 5 languages are Spanish, French, Bangla, Mandarin.
Mandarin. Okay. One of the things I'm going to iron out, is that still going on, that doctors, providers, medical providers not talking about sexuality with folks with disability? For me, that's old age. I mean, before I used to hear it, but are it still going on?
Well, this is research and a national level. So, but it was, I think, 22, so it's still current.
I never can understand that. I'm thinking like it's a human being and you think, okay. MOPD's former commissioner testified in April 2025 that inaccessibility exam rooms and diagnostic equipment, communication barriers, and lack of culturally competent care remain works in progress. 14 months later, which of those have been resolved? What relevant data can you share with this committees? Anybody can answer.
Yeah, so I will defer to the health department and H&H for specific facility-related questions. But the Mamdani's administration takes the work very seriously and is committed to the progress. As I mentioned in my testimony, with the deputy mayor and I visited NYU to see good models, and we'll do a roundtable with women with disabilities to continue this conversation with community partners with lived experience. And so that's our next follow-up from that.
It's all great when we talk about NYU, but truly, NYU is not a reflection of delivery care of all New York City, because we know that in the Black and brown communities, that is not possible. And I'm not blaming them, because the reimbursement sucks. Medicaid reimbursement and all the cuts, we have more trouble to deal with. So thank you for your advocacy and everyone here to continue fighting for that. As of today, how many of DOHMH facilities and how many H&H sites meet the requirement? How many facilities and sites do not currently meet that requirement?
Due to the services that we currently are providing.
Okay. And about H&H, Dr. Cox? This is my card.
Sorry, thank you. Health and Hospitals complies with all state, local, and federal requirements related to the ADA. We're a public agency that is governed by federal CMS, State Department of Health, and New York City Department of Buildings, all of which outline the needs of people with disabilities. H&H is constantly assessing our equipment and policies to address any gaps in care as legislation and regulatory requirements are updated.
We can dive into it a little deeper, but for now, I'll do to your knowledge, or H&H, what capital investment has H&H committed specifically for MDE and structural accessibility fixes, such as doorway, width, and examining room?
So H&H, as stated previously, complies with all state, local, and federal requirements related to the ADA. As I said previously, we're a public agency governed by federal CMS, State Department of Health, and New York City Department of Buildings, all of which outline the needs of people with disabilities. All H&H facilities have hallways that are large enough and do not restrict travel with wheelchairs. All H&H hallways have handrails to assist people that need more stability when walking. All H&H bathrooms have accommodations such as wider stalls, heightened toilets, and insulated piping below sinks. Access ramps are installed in all H&H buildings to facilitate movement throughout. Elevators are easily operated and have ADA compliant controls. There are also instances where we make accommodations for people with additional needs that are not addressed by building code, such as ergonomic furniture, lighting upgrades, and automatic doors.
Okay. You're talking about all the buildings are wheelchair accessible, all the, you can access all of them, because there's some old building that I know, some old structure that you have been limited to upgrade. So I'm going to leave it as this, because the chair probably will go dive into those more. Since I have to run, guys, so I'll go to accessible medical diagnostic equipment, or MDE, is a critical component for equitable reproductive and maternal health care. Do any H&H labor and delivery units and prenatal clinics have accessible MDE and accessible birth rooms?
So yes, we have accessible MDE and accessible birth rooms across our system, and our birthing beds are designed for safe, flexible childbirth care, and so it does allow for height adjustment for easy transfer across, from the bed to other modalities. Also, built-in grips and a labor bar for additional comfort and leverage during delivery. So we have tried to accommodate for that.
What specific accommodation exists for patients who use wheelchairs? So if a patient with disability, sometimes it's not all disabilities as alike. There's different part of things that may be all disabilities as alike. There's different part of things that may be not, working. So maybe the limb, it can be something else, it can be the back where the person can move. So do you have all the equipment required to make that person from the transferring, from even be in that bed, in that stretcher?
So our staff is highly trained and would absolutely assist the patient in transfer.
Okay. And one of the things, because I used to sell DME, I was a provider for DME. One of the things that always came across is just like some chairs are limited in size. You don't have all the size. Your doors are restrictive. You know, I've been there, done it. Registered nurse and selling DME. So that's the reason I'm going with that question with you. Those chairs are provided are really suitable for all sizes. Do you have all sizes across the board?
We absolutely do. You know, this was taken care of a while ago where we have wheelchairs that are able to accept certainly higher weights, as well as birthing beds and OR tables that are able
The
to.
tables are too. Okay, thank you. H&H obstetric staff train, you said they all train. So
For the patient as well.
because let's say if I'm blind, I'm aware of what's going on. What is that from the get-go? It's not a person with disability is not a person that just walk in like, I'm walking in. They have different things. They have a lot of fear going on, and especially when we talk about even somebody's pregnant, come to deliver, and knowing that I have a limited, ability to do everything that I want to do. Do you provide all that from the get-go, all the instruction and?
So from the very beginning, we provide this training to all staff. We also provide staff with disability ally buttons so that individuals with disability, as we know, not all disabilities are visible. They are able to, the patient is able to approach any staff and ask them about any special accommodations that they may need.
Do you have some kind of like a doula that you can partner that within the structure to make that person easy? Because that's a lot going on for somebody with disability delivering.
So we are open to partnering with all of the staff.
I can have a lot of questions, but I might gotta run. Okay. The U.S. Department of Justice, Title II, final rules requires that by August 9, 2026, roughly 8 weeks from this hearing, every covered facility that uses exam tables and weight scales have at least one accessible exam table and one accessible weight scale. As of today, how many of DOHMH facilities and how many H&H sites meet the requirement and how many do not, if you're aware? Who's gonna go first?
For the health department, all of our clinics are compliant in regards to the beds. And as I mentioned previously, we do not have scales because weight is not necessarily needed for the services we currently offer.
Last time I heard the scale are too expensive. You don't know how many, but but now let's go back. How many folks with disability that gave birth within a year at H&H or in the city of New York? If you're not buying the scale, it's because how many that you're delivering, you may have the statistics saying, okay, you have one, and the scale costs $2 million. I'm just giving an example.
Well, we don't provide delivery services, so I'll defer to health and hospitals.
No, do you know that they're providing it? Because if you're Department of Health.
We do know. We work closely with our partners, health and hospitals, and many other institutes across New York City.
Okay, so you don't have it, so I'm gonna turn back to H&H.
I'm sorry, can you please repeat?
For the hospital.
Yeah, so I'm unaware of any facilities that are not ADA compliant.
So you have scale for your patient? You don't have?
At this point, we would have to, I would say, have scales that are compliant with ADA. Might not, at this point, able to,
All right.
I'd have to get back to you with that.
Okay, no problem. Because H&H and DOHMH, one accessible exam table and accessible, the scale, and then I'm gonna go to the next one. The agency tracking compliance against both rules, and is the earlier section 504 deadline reflected in procurement?
And that we are complying with them.
You are compliant with them?
H&H is constantly assessing our equipment and policies to address any gaps in care as legislation and regulatory requirements are updated.
My last.
We are tracking it.
Mhm, you are tracking, okay. My last question. Women and other birthing people with disabilities are 2.5 times more likely to experience intimidated partner violence, IPV, in the year before and during pregnancy. Yet, IPVs is routinely missed in screening among the populations. Is accessible IPV screening built into well women and prenatal visit at H&H and the sexual health clinics?
Yes, for health and hospitals, intimate partner violence screening is built in.
Okay, thank you. In what ways do you work with the mayor's office to end domestic and gender-based violence to track and reduce IPV among women and other birthing people with disabilities?
H&H has many different representatives that serve on committees with NGBV to track and reduce IPV across all populations, including women and other birthing people with disabilities.
And I'm going to leave it with that. Wilcox, thank you for your work. I have seen you, follow you, appreciate all of you, and I'm passing it back to Chair Hanif. Thank you, Chair.
I'd now like to turn it to Councilmember Sylvina Brooks Powers while we have quorum.
Hi, good morning. Chair, can you hear me?
Yes.
Perfect. And thank you for the testimonies to the agencies present. I just want to ask 3 quick questions, and I'll just ask them at one time in the interest of time. The first is, many New Yorkers with disabilities continue to report barriers when accessing reproductive health care, including inaccessible facilities, medical equipment, and provider training. What specific steps are health and hospitals and DOHMH taken to ensure that reproductive health serving the greatest maternal health disparity, fertility services, and maternal health supports are equitably accessible across all boroughs and neighborhoods, and what gaps have been identified in Southeast Queens and the Rockaways in terms of services from your agencies? Thank you, chairs.
Were you all able to get that?
I mean, I think it'd be easier to answer them one by one.
Go for it.
Absolutely, yep.
Oh, but if you could just ask it one, I'm sorry. Again, it just, first question,
Okay.
please. I'm so
Sorry. So the first one is, many New Yorkers with disabilities continue to report barriers when accessing reproductive health care, including inaccessible facilities, medical equipment, and provider training. What specific steps are health and hospitals and DOHMH taking to ensure that reproductive health services, including prenatal care, fertility treatment, and abortion care, are fully accessible to patients with disabilities?
So for health and hospitals, we provide care to all patients, irrespective participating on with our reproductive working group to identify site-specific issues and then bring them across the system. We abide by our eye care values. We have trainings that people have to do on an annual basis in terms of anti-bias training. So I would say that all of that would work toward ensuring that we are offering care to all patients, including people with disabilities.
Thank you for that. And Black women in New York City continue to experience disproportionately high rates of maternal mortality and severe maternal morbidity. How are the city's reproductive health initiatives, including doula services, fertility programs, and sexual health clinics, being targeted toward communities experiencing the greatest maternal health disparities, and how will success be measured?
Well, for the health department, the priorities are to reduce the maternal mortality rates in New York City, and we're addressing that by area of programs and services, resources we offering, including our doula programming. We definitely support the intent of the support and with our partners. So we are continuing assessing, and we do conduct trainings for our staff as well, and we do have greeters along our clinics to really assess those needs, but most importantly, collaborate with our partners as well for those additional services when required.
For health and hospitals, I'll say that we have long been aware of the disparities in maternal mortality and severe maternal morbidity. All of our acute care facilities for prenatal patients have something called the maternal home, which really offers wraparound services to patients with identified needs for either behavioral health issues, complex clinical care issues, or identified social determinants of health. And through that care navigation, Health and Hospitals is the largest referral source for the citywide dual,
including abortion care, fertility services, and maternal health supports, are equitably accessible across all boroughs and neighborhoods, and what gaps have been identified in the Rockaways and Southeast Queens. And I'll just, share from a personal experience myself, having gone through fertility treatment and also just through prenatal care. I often found myself having to go to Manhattan for certain treatments and Long Island for care, as opposed to being able to go locally in the neighborhood. And those were even with largely private medical institutions, because there wasn't really a presence from the city health institution. So I'm just interested in terms of how these two entities are evaluating whether reproductive healthcare services, like what those look like and what gaps have been identified, and what's the plan of action to address those?
I can go first for the health department. So reproductive health and abortion are cornerstones of our basic health care, and access to those services is a public health priority. We are committed to protecting abortion and reproductive health care services for anyone who needs them. We do have our hub, that is a confidential hotline that connects callers to abortion care and related services.
And fertility treatments as well.
As for fertility treatment, we do not provide. I could defer to Health and Hospitals in regards to fertility treatment.
And before Health and Hospitals chimed in, I'm sorry, when you talk about the abortion services and the hotline, could you tell me what the nearest location, if someone needed that type of care, would be for someone out of Southeast Queens and the Rockaways? Would they have to go into Manhattan? Would they have to go to Northern Queens or Brooklyn? Like, where would they have to go to actually get these services?
Well, through the Abortion Access Hub, we connect them through various partners, not just the sexual health clinics. So we also depend on our Health and Hospitals as well. And many times when needed, we utilize their Virtual Express for medication abortion as well. So at times they necessarily may not have to come in to the city, depending on the type of services that they're seeking. So we do coordinate based on their needs.
But if someone is seeking an abortion, they likely would have to, because the only presence of Health and Hospitals we have a Gotham Center in Springfield Gardens, and we have a Gotham Center that is being built in Far Rockaway, which I don't believe this service, as of right now, is going to be one of those administered. So where would the nearest one be?
And Councilmember, if you could wrap up.
Yes, I'm sorry, Chair.
So as I mentioned, I don't have the list of all the but we can assess them through the NYC Health Map, and we do work with various partners throughout the city, including in Queens. And again, for those necessarily that may not travel, we heavily depend on health and hospitals for the telemed medication abortion option.
Thank you. Chair, I know Health and Hospitals was going to answer. Can they answer, and that'll be it?
Go
and
for
I'm
it.
done.
Yeah.
Thank you.
Sure, thank you. So telehealth abortion is located all over the city, and we certainly receive referrals from the abortion, health helpline. I will say that all of our acute care facilities, so we have 2 in Queens, Elmhurst and Queens Hospital, do offer procedural abortions if that is needed. In terms of fertility treatments, Health and Hospitals has the ability to diagnose and treat conditions related to hormone dysfunction. However, we do not offer any assisted reproductive technologies such as IVF or
that both you and I have in accessing the healthcare needs and resources associated with our chronic conditions, and really highlighting the inequities that exist, and which we are, of course, trying to address and solve for. So I want to first get a better understanding of how each agency is working together. How are the 3 of you working together to inform the conversation on reproductive healthcare access for people with disabilities?
So maybe I'll start. Thank you for raising that question. We are in constant communication with Health Department and H&H, and Mayor's Office of People with Disabilities will continue this conversation on a range of issues. For example, we have disability services, I always get the acronym wrong, disability service facilitators in every agency who are responsible for ADA compliance. And we have regular meetings every month. We do office hours if they have questions or concerns, and we have convenings 2 times a year, and arrange even a field trip for DSS if they can get that, because you're moving from theoretical to real world experience on a disability and healthcare. So we are always looking to strengthen our partnerships and look forward to working with H&H and hospital department.
So more specifically, in terms of the day-to-day you mentioned, given the data on how many New Yorkers are living with a disability, what kind of convening has happened specifically on New Yorkers with disabilities? And if there hasn't been, that's totally okay too. I'm just trying to understand the function of how agencies that should be working in collaboration are, and if not, why not?
Yeah, so if a DSF person asks questions or confusion of the different issues, they can reach out to Mayor's Office of People with Disabilities, and we can help in resolving that question. So that's like one way of partnering with both health and hospitals and health department. And we do this with other agencies as well. And I think that's very helpful because if the person has an ADA question, they can just call us. We have expertise. They have the expertise on the department that they work on. And so we collaborate well, and it's been very effective.
Hi. So for the health department, we view MOPD as a valued partner in our efforts to make our facilities and our services more accessible. MOPD oversees the 5-year accessibility plan process, and my office, which is the Office of Access and Disability Justice at the health department, has collaborated with MOPD to provide physical and digital accessibility training. I am the DSF, and I also attend the regular DSF monthly meetings as well as community meetings in collaboration with MOPD. And we have a digital inclusion officer and members of our communications team who have participated in digital accessibility training that was provided by MOPD.
I'll come back to you once I hear from Dr. Wilcox.
I'll just say that we collaborate with MOPD as previously described.
Okay, so I'd like to better understand, Amanda, you mentioned that you are the DSF at DOHMH. What are your responsibilities?
Sure. So my responsibilities are to ensure that the agency is in compliance with local, state, and federal ADA compliance laws, as well as to be a liaison for the public whenever there's a concern or a complaint regarding our accessibility, and to escalate those concerns to the appropriate parties within the agency.
And are those complaints coming through 311? How are patients accessing you?
So they can come through 311 as well as an email address, mail, or phone.
And that's specifically about complaints or concerns about access?
Correct.
Got it. And then what about for H&H, your DSF?
We have an identified individual also that is responsible for looking at any accessibility issues. We work closely also in collaboration with the Office of Disabilities. But in addition to that, we also have a patient grievance mechanism. So any patient that comes in, according to the Bill of Rights, they are able to register a complaint or a request for assistance. That information is posted at all of the facilities, and we have a dedicated email for individuals to put complaints into.
And are you all tracking these complaints that are coming in? Are you able to share any data with me as to how many over the last year?
So to date, we have had no accessibility complaints coming in through our emails.
Got it. And then for
The same is true for us.
Same
There
is true.
haven't been in the last 12 months.
And how would a patient know about the patient grievance
Sure.
process?
So the information is posted at all of the facilities in a clearly marked area via posters. It is also available for our patients through our digital services, our external facing websites.
Got it. So it's not such that a doctor interfacing a patient would be sharing, here's how you can access.
The limitations that necessarily we have in access and outcomes, referrals and diagnosis. So it is something that, despite New Yorkers' coverage and requirement, something that we are working with necessarily partners. We do through referrals through our social workers to better understand their needs. So when they do come into the clinic, if it is a service that they're seeking, we try to work with collaborating partners on what that access may look like, what that cost may look like, and then kind of inform the patient on that process.
So there is some in-house kind of interaction available.
It's more of us being like the referral pathway. So we're the entry point for individuals and try to be the referral pathway on what's assessed, on what's available throughout the city.
And it's not necessarily saying, giving a referral, but rather listing out options available.
Correct.
Got it. And is anything distributed during that communication?
No, it's more we try to make warm handoff via phone. Social workers tries to assess, the capability or ability to make those referrals based on what's available.
I mean, I think that there have been conversations, and there is a referral system. I think that really speaks to why I'm I've introduced my legislation. Now, when you talk about referral, are you referring out to an H&H site, or are there private facilities you all are also partnered with and referring there as well?
Yeah, we're partnered with private as well. So really assessing kind of like the cost. I think the biggest barrier for us that we're seeing is coverage, just because of the patient population that we do serve within our clinics, predominantly tend to be uninsured.
Got it. And, my bill doesn't say that DOHMH has to cover the process. However, I think that is an important distinction as well, that many New Yorkers who are approaching reps from DOHMH are uninsured. And again, I think that speaks to why this awareness and education is important on our city's resources on fertility care. So again, when there's referrals being shared, this is like just spoken conversation, not a written.
Correct.
Got it. Okay. So that to me isn't helpful. I mean, I also visited recently for fertility care and received a similar conversation and took down notes. And it's very overwhelming, first of all, to receive information, particularly if the patient is unable to give birth, and then considering a process that is so expensive, and there is so little information about fertility care just in general, that the onus falls on the patient to fully understand what to expect during this process, or talk to others who've already gone through the process to better understand. So I think DOHMH and a partnership with the two other agencies here on fertility care available and giving some attention to people with disabilities is incredibly important, and I think absolutely urgent. I think your responses really speak to exactly why we need to pass my bill. I want to pass the mic to Councilmember Sanchez. Oh, she left. Okay, she's going to send me questions. I want to pass it to Councilmember Epstein.
Thank you, Chair Hanif, and thank you all for being here. Commissioner Algoa, congratulations. And I want to talk about how we grapple with these issues. Obviously, MOPED's an important agency. We see issues around healthcare related for people with disabilities across the board and really being worse, especially for women of color. Kind of what is the agency doing to try to get in front of it? How do we kind of system-wide change the process? I think there's a really good package of legislation here, but we have underlying problems that are really hurting women of color and women of color with disabilities, and I'm not sure we're getting to that.
Yeah, so this matters for me personally. So the first thing is we don't want to just comply. We want to be the best in the country, in the world. And so best practices in health and hospitals, in health department, and other agencies like NYU. It was really remarkable to see that any woman could walk in and get the care they needed, and it affects the bottom line. And so I think that's very important, is sharing the best practices. And then we're doing a roundtable with women with disabilities, primarily people of color, to explain some of the problems, but we wanted to focus on the solutions for hospitals, doctors, facilitators at every level. And then we're going to use the next steps at the end of that is how are we going to move forward to move this problem ahead? And it takes time, it's organizing, but we're trying to create a system where it is not just compliance, but it's world-class.
It's part of the plan to encourage people to be hiring or setting requirements of hiring people with disabilities so they're more sensitive to those issues. Like, what gets us over this? I appreciate the roundtable and I appreciate the work there, but hopefully that roundtable will come up with real concrete solutions about how we kind of broach this problem.
Yeah, and I think also we do employment, and we do that for job seekers and employers, and recognizing that people with disabilities want employment. And so having the interconnected work for healthcare and employment, for example, is a great strategy to move forward.
Do you think that they could include requiring or having set-asides for those, for people of color with disabilities or people with disabilities to make sure those entry roads are in our government jobs?
Yeah, and so we work with DCAS on 55A, which is city jobs for people with disabilities that don't require an exam. So all of the stuff can be used in employment to have people get employment, and we will work with H&H and Health Department to do have people, employers who are disabled and work in there.
And is there a procurement piece? Because obviously part of our government dollars isn't just around hiring, it's around procurement as well.
Yeah, so we're not involved in the procurement, so I can't share that information, but we can talk to the OMB on that.
I would love, because obviously that's a really good opportunity as well to then, not just in our hiring, but whatever we're procuring allows like this to be infused within our network. And in some ways, like to get to these issues requires, I think, a real sensitivity that unfortunately in our current system doesn't exist.
Yeah, and I mean, I think like in your district, there are Tanya Towers where there's a huge amount of deaf people, and like working with city council members is crucial to like partnering our agencies and our city council members.
Yeah, well, I would love to go there with you.
Yes.
I've been working with that building, dealing with issues over the years. I love that partnership, but also expanded opportunities on this kind of reproductive health issues to kind of be a partner on that as well.
Thank you.
Thank you very much. Thank you, Chair, for the time.
Thank you, Councilmember. So with the Local Law 12 of 2023, every agency needs to publish an annual accessibility progress report and then submit it to MOPED. With the August 9th medical diagnostic equipment deadline looming, is MOPED specifically tracking health agencies' MDE compliance through that reporting framework, and would MOPD share that reporting to these committees?
Yes, so we're not, we don't get the information to MOPED, but we work with H&H and hospital health department all the time, and we will continue that progress.
So you're saying the accessibility progress report is not supposed to be submitted to MOPED?
It is not.
Got it. Do you know where it is being submitted? This is a question for health and hospitals.
So there is a site. We publish our plans on our own public-facing websites. So the plans and the progress reports are on our public-facing websites. I do know that MOPED does have a site that has all of the accessibility plans on it.
Got it. And how are you all doing with the upcoming deadline?
I'll add that we are continuing to help with health and hospitals and health department to ensure that by August that will be done. And so after this meeting, certainly, and before, we're going to continue to meet this deadline, but it's not just meeting the deadline, like moving forward to make our city more accessible with women with disabilities.
And then once the reports are available, will MOPD share its observations or concerns or comments to the agencies?
We can share that with you because, again, it's very important for me that we're doing not just compliant, but getting better at doing that. And so everything from the roundtable to this rule, all that stuff will get more involved with my leadership.
For DOHMH, what is informing the accessibility progress report?
So we developed an accessibility committee that has representatives from all across the agency, and those 30 representatives help to inform the progress that we have made and any gaps that remain. And we also work in collaboration with any of those concerns or complaints that come through my office to ensure that they get incorporated into our.
And are those folks from the agency, or is this a contracted partner?
It's multidisciplinary from the agency, so all of our partners, so for example, digital, hospital police, facilities, anyone that has a piece in the game.
Understood. Does DOHMH and/or MOPED coordinate with the Department of Education to ensure sexual health education curricula developed, or rather delivered in schools, are accessible to students with disabilities, including those with IEPs and 504 plans?
I can start. So we're working with DOE or NYC schools on a range of IEPs and District 75 schools, and a range of issues, not just sexual health, but we're discussing ways that we can work together on that, and my hope is we will add health for children in the plan.
Do you know if currently there is something that the DOE is distributing?
I don't know. I think you'd have to refer that to DOE.
And then does DOE's DSF also participate in the, did you say it was a monthly convening?
Yes, and they do, but I don't know the name.
Okay. And each agency has one DSF designated?
Yeah, and then as Mandy said, we also have the digital accessible facilitator, again, really bad with the acronyms, that does disability accessible trainings and have the same rhythm.
So in this instance, once the conversation sort of is teased out with the New York City Public Schools, would MOPD be playing a role in supporting them with the sex ed delivery in school settings?
Again, we're discussing a range of issues, and so we'll see what we focus on first, but this is always a consideration for us, and it's important.
I'd love to hear from DOHMH.
So DOE is responsible for the development and distribution of materials. The health department coordinates with DOE to contribute to the development of their sex ed materials.
Okay, so there is a collaborative, ongoing partnership, it seems. Are you able to share the materials that have been developed for DOE specifically?
So we provide the sexual health content for their education delivery, but I don't have that today.
That's okay. And do you know, is it developed by DOE, or is it a combination? Because, you know, third to fifth grade versus sixth to eighth, high school, what do you know what sort of breakdown of information is available to the diverse age groups?
So I believe DOE would have to answer that. They are responsible for the development and distribution. We just contribute and coordinate with them on materials.
Okay. Commissioner Agarwal, I wanted to hear from you a little bit more about the NYU initiative for women with disabilities and share what you observed, saw, and how you think our city should be replicating for our city services.
So as I mentioned in the testimony, it's like external, like exam tables, weight tables, all of that was accessible. So all of that was fantastic, and seeing it in person helps a lot. And so, and then internal data sharing, including disabilities, including procurement. The director of RUSC, which I spent a lot of time with, works with another hospital, another physician who does trainings for providers in healthcare settings. And it's huge. It's a huge volume, but it's like, this is simple. You just take that training and you share it to other hospitals in this city and other cities as well. So those are some ideas that we learned in this conversation, and we're going to continue to take that up.
Great. And then for the training that is available for staff and healthcare workers, could you share what is included in that training in regards to how to accommodate people with disabilities, how to work with people with disabilities?
So we work with internal internal partners as well as external vendors. In the disability training, basically what it does is allow for providers and for all staff to be able to identify different types of disabilities, whether visual or not, and in addition to that, how to be more inclusive of individuals with disabilities, how to create inclusive environments, how to communicate with individuals. In our low-blind patient experience trainings, individuals are taught the experience that a patient has navigating a hospital system. So the clinicians or anyone who attends is outfitted with accessories to have them feel and actually have them navigate in a world where a patient may not be able to see, may have challenges in seeing adequately. And so that is done with the effort that clinical and non-clinical staff will be able to assist an individual by experiencing what they are experiencing.
And you said that this training comes from an external vendor?
Yes.
And who is facilitating the training?
The external vendor.
The external vendor, got it. And do you know how long Health and Hospitals has been working with the external vendor?
Approximately 2 to 3 years.
Got it, so somewhat new.
Yes.
And is the training updated?
All of our trainings are consistently monitored to ensure that they are up to date with any recent legislatures and also with the content.
And how frequently are employees getting this training?
This is offered on a regular basis. We do it right now. The disability training is being offered, I want to say 2 to 3 months, every 2 to 3 months. The low blind patient experience, because that is heavily resourced and it is an in-person, that is held twice a year. So we are now getting ready to do one at Jacobi Medical Center, and it is open to all staff.
Okay, so is the disability training mandatory?
The disability training is not mandatory at this time.
Got it. So how and how would one decide to do this training?
So individuals, first of all, we try to make them accommodating to all. So we try to do them during lunchtime, and we try to make them short programs.
Why is it not mandatory?
At this point, it's not mandatory. We can definitely explore that.
And can you share how many staff have received this training in 2025 or just the first 6 months of this year?
I don't have that information readily available, but I'll be happy to provide that.
That would be great. And then what about for DOHMH?
And before that, I have to go. I'm
Yes.
very sorry.
Thank you so much, Commissioner. Really appreciate you. And good luck.
So we currently have 2 disability justice trainings that are available to all staff, including staff at our clinics.
And is that coming from an external vendor?
No, it is not.
That's internally
Correct.
created. And has there been an exchange between the 2 agencies about the training that your staff are receiving, given that it seems Health and Hospitals has a private external vendor, DOHMH has an in-house created training?
So we are happy to partner. We have participated in the past with trainings. We like to offer a variety of trainings, so we would keep the variety available to all staff.
Same here, we're happy to partner.
Got it. Okay. So, look, but currently, it's not as if
Right.
you've exchanged the materials and said, "Oh yeah, we could use this," or "Oh yeah, like this is okay." And then, is the training for a DOHMH staff mandatory?
It is being required for our clinic staff. We have sessions planned at the end of this summer.
And how? So, you're saying that it takes place during the summer months, or how frequently are these trainings offered?
The next one would be coming up later this summer, and all of our trainings are mandatory for our staff on an annual basis. So we do keep track of those individuals, especially as new individuals come on, how to necessarily we accommodate those trainings.
Okay, so just to be clear, DOHMH does require its staff to receive this disability-related training.
Correct.
Clinical staff.
Clinical staff.
Clinical staff, okay. So then, and you said that it's happening throughout the year.
Correct.
Absolutely, we will extend the invitation.
Thank you. Okay, so Dr. Iviles, correct? Did I pronounce it?
Iviles.
You said that the training is being provided at Jacoby. Could you just speak a little bit more about why at that location, and is the training rotating to different sites?
Yes, we are currently working our way through all of our facilities. Our last training was in Queens, in one of the hospitals, and now we will be at Jacoby, and the goal is to go through all of our different health and hospital facilities. Right now, we are doing them upon request, so when an individual facility offers their site up, then we will go over to that site. That particular training, the low and blind patient experience, is in person, so it requires us to have ample space to train, because we do set it up as a clinical environment while it's going on. It's a simulation program.
Understood. And I would like to receive.
That is a virtual instructor-led program, and so that is held on an ongoing basis. And then we have the low blind vision, which takes place at every different facility.
And are doctors participating in this? What's the breakdown of who's
I
participating?
don't have the exact numbers in front of me, but we have all disciplines participating.
All disciplines.
Yes.
Okay. And again, it is not mandatory.
Correct.
Got it. Earlier in the hearing, Joaquin, okay, You mentioned that weight scales are not in,
Options, based on that self-report, the clinician would make that medical indication on which option.
so self-reported BMI.
Correct.
And why does the agency think that that's okay?
I think it's something that we're assessing, so we can definitely circle back.
Got it. Because, I mean, that seems, I mean, of course, we want to trust patients, but it also seems sort of counterintuitive. And I'd like to better understand why the agency does not see having accessible weight scales as a need.
Yep.
I have a couple questions from Councilmember Sanchez that I'd like to read out. For the Corona Sexual Health Clinic, could you elaborate on the renovations that have been completed and specific? Got it. And so is there any other construction remaining on accessibility?
For that particular location, not at this time, I don't believe.
Okay, and also these questions are from the committee. For accessible weight scales, and this is directed at H&H, what's the process for ensuring that those with disabilities who may not be able to use standard weight scales are weighed accurately?
We offer a variety of scales that would be able to most likely accommodate most disabilities, although I'm not at this point willing to say all, but
Got it.
we would offer a variety of scales.
Okay, I would love to check out the weight scales available, and would want a better, sort of more accurate response on which disability communities are covered in the current equipment. For the, great, and then for Councilmember Sanchez, Councilmember passed Intro 435 of 2024, now Local Law 84 of 2024, to expand same-day rapid testing for chlamydia, gonorrhea, and HIV across New York City, especially for communities that continue to experience deep inequities in rates of infection and face disproportionate barriers to sexual health care, including Black and Latino New Yorkers, LGBTQI+ New Yorkers, immigrants, low-income New Yorkers, young people, and people with disabilities. The law requires 3 sites to be operational by February 15th, 2026, and a 4th by February 15, 2027. Were 3 additional rapid STI testing sites operational by the February 15th deadline?
This is the Health Department. So we currently do have Chelsea and Fort Greene operational. Morrisania is to open later this week. It did require some construction retrofitting to support that, and we are already on plans for a Corona quickie rapid testing in 2027.
Got it. Okay, so then by the 2027 deadline, you will have 4 sites.
That is correct.
Great. And then which community-based organizations did DOHMH contract with for the required outreach campaign? And how were those partners selected to ensure outreach reaches the communities most impacted?
So currently we are contracted and partner with Voces Latinas out in Queens to focus on a lot of the work within that space. And that was done through a bid.
So just that one?
That's the current one that we currently have.
Got it. And they're doing citywide outreach, or specifically, is it geographically confined?
specifically Queens, but we also work with other partners. That's not the only partner, but that partner we fund to do a lot of the work. And that was really focusing at that time, 3 years ago, and we launched that to focus on Latino MSM to really engage those individuals within that community of our services because they. Can you repeat that?
Sure. I wanted to better understand if patients with disabilities are receiving any counter information about their access to contraceptive counseling and STI screening at the same rate that patients without disabilities are receiving.
Yeah, for our sexual health clinics, we have greeters up front to really assess what their needs are when they're coming in, regardless of their ability, and then we would accommodate accordingly for the services they are seeking.
Got it. And for the sterilization, are you able to share data as to how many patients may have been sterilized over the last year? Is that data that you all are tracking?
Actually, we can get that data because all of our acute care sites are family planning sites, and so we submit that data on an annual basis.
Okay.
Yeah.
And so off the top of your head, you wouldn't know about the specific sterilization that may
No,
have.
but I will say in general with long-acting reversible contraception, that being introduced probably now a decade ago, and big pushes from DOHMH as well as ACOG and other entities into the reproductive care world.
How is do you know if the translation or the interpretation is through community feedback, or if the interpreter is a medical interpreter? Could you share a little bit more about the language access?
Absolutely. So we have 24-hour, 7-day services for interpreter access. We contract out with Propio. We offer 3 modalities. We have video remote interpretation, in-person remote interpretation, and we also have by video. In addition to that, we offer MIS classes, and MIS classes stands for Medical Interpreter Skills Training, and that is for staff who speaks a second language, where we then assess them in terms of their competency in that language, and then we train them to be able to provide interpretation.
And how many staff are qualified interpreters?
I don't have that number, but I can get that back to you.
And how frequently are staff getting trained?
We offer the training every year.
Every year. Okay, so like once annually.
Yes.
And what does the training include, and what are the responsibilities for that staff member? Because I'm assuming that staff member has a full portfolio already.
Correct.
And then providing their language access expertise.
Sure, give me 1 second. So one of the things that we find, and we actually promote the program as part of their onboarding, so when they come through the system orientation, we let them know that this program is available to them. When staff speaks a second language, we find that they're very proud to help other individuals. So at that moment in time, immediately we start receiving requests for individuals to participate in the training. So in addition to that, once they complete the training, they are able to then volunteer their time if they wish to do so as a supplement to our interpreter skills that we have.
Access is actually really amazing. It's like the patient can see the person doing the interpretation and the translation, so can the provider, and it's actually a very, a really well-working modality.
I think that's really wonderful. 18 years ago, when I was diagnosed with lupus, I really struggled to explain to my parents, who are limited English proficient, exactly what was going on. And the hospital, which I will not name right now, had very limited resources when it came to being able to talk to family members about degenerative autoimmune conditions like lupus. And so knowing that we have this modernized tool and access for patients who would require interpretation services so that the medical language is understood by the family is just so important, and I'm really grateful to know that that exists. Do you know how often or how many times this service is getting used?
Ooh. So we provide over 353 languages, 24 hours, 7 days a week. And I can tell you that every month I monitor the data. It is in the millions of minutes provided.
Oh, wow.
Yes.
Yeah, well, we are grateful to
And
H&H.
that's only interpretation, not translation.
Got it. And then for the translated materials, are the staff who are trained, who speak second language, are they providing feedback to those materials?
We use a vendor for our translation materials.
Got it. So the vendor creates the materials. So there's no sort of like advisory committee that's like, oh, this is jargon or this is.
We create the materials. Sometimes the material is created in-house. It is then sent to our vendor. The vendor then sends it back, where we also do a final review before actually putting it out.
Understood.
And wait, I'm sorry, it's not just for language, it's also for grade level reading ability.
Yes.
Excellent. And then what about for DOHMH?
Same, we do all of our translation in-house through Office of External Affairs, and we work with partners as regarding to access to language. We have Language Line, we also have the interpreters and video as well. For our staff, we do have competencies tests. In order for them to be able to translate, they do need to pass that test before they're allowed to translate.
And how frequently is that being offered?
We're continuously assessing because we're continuously getting new staff coming into the clinic space on identifying if that's something of their interest, if they have that as a second language, and then we'll work with our internal folks on getting them scheduled for that test.
And do you know how many staff members have taken this competency test and are formal interpreters?
Yeah, I can get back to you on that number. It does range throughout clinicians, nurses, registrars.
I think that's great. I think it's transformative that we've made such strides in the language access field. And our staff members who have this expertise now also providing this extra service at times, are they getting paid more than someone who is of their same title but is not an interpreter?
I can't really speak on the pay. I don't know. I don't believe so. But that's something that we can assess and get back to you on.
What about for H&H?
Our contracts are collectively bargained, so they are currently paid the same amount.
Got it. I would like to know from each agency what your understanding of disability justice is.
So I can speak for the health department. So disability justice is an intersectional framework that realizes that people with disabilities do not experience that identity in isolation. And so we are working to really embed disability justice principles into our daily operations.
Thank you. And how would you rate the city in being one that is disability just?
So New York City is definitely a leader. I can speak more closely to what the health department is doing. We have been recognized by MOPD as a leader in this space and the work that we're doing, and we continue to try to embed disability justice into our work and transform our workplace culture.
And then when it comes to the other pieces related to access to healthcare, like transportation, like when a patient is discharged and their home is not ADA accessible, how is that interaction taking place?
So when an individual is discharged and
Yeah, I'm trying to understand, so both agencies have disability trainings and are equipped, it seems, for the most part, to be able to provide to any patient. It is inclusive service. However, there are other barriers that make our city inaccessible. How is that conversation happening with patients? And also, I would love to hear from H&H on the disability justice piece.
So I can speak for the clinics, and on really that conversation is being had on the social work level, really assessing those needs, and if there's additional needs that they need support on, our social workers are equipped on working with various partners to addressing some of those needs.
So I'll start off with the disability justice. So our view of it is that all individuals that have a visible or invisible disability are treated with equity, treated with respect, and treated in an environment where they feel included. In terms of the latter, that's part of the patient's care plans, so that is usually addressed by the social work team.
Got it. And then do our services allow for materials or equipment to be sent home with patients? Or is that coming from the health insurance? Like, let's say a walker, crutches, a wheelchair.
Those are durable medical equipment, would need to be prescribed. So-
Got it. And so that's approved by the health insurance.
Yeah.
And if a patient does request any medical equipment, how do you all go about that?
We would write a prescription.
Okay, got it. So essentially what I'm trying to get at is, like, if somebody needs a cane, they
would get it.
yeah, okay.
I mean, I think that's also a difference between inpatient and outpatient, right? If it's someone who's inpatient, generally before their discharge, you order like a consult, a physical therapy consult. They come, they assess, they would give the patient what they need, and they would work with the patient to use it prior to discharge. I mean, that's usually how that works.
I want to come to some of the legislation. For Deputy Speaker Williams's bill on access to medication abortion, could you share what the agency's plans are for expanding to more clinics? And are you able to provide specifics, which clinics, when they will begin offering the service?
Yeah, so I can start off by saying that we're extremely proud of the success of our medication abortion program at the New York City Sexual Health Clinics. We are providing high quality, high accessible care to equity priority groups. We do have available walk-ins Med-AB services across our clinics that are providing Med-AB, and we do have our telehealth pathway where patients can be pre-screened for clinical eligibility. As for expansion, we heavily do rely on our abortion access hub that really helps and assess the individual's needs, which location is convenient for them, and really working with our partners on linking them to those clinics if necessarily our existing clinics are not accessible. We currently do not have any plans to expand medication abortion services. We're currently focusing on expanding and enhancing other clinical services, including gender-affirming hormone therapy, a pilot that we're going to be conducting at Corona Clinic, planning on the expansion of the quickies, as well as I recently mentioned, which Corona is another location that the expansion will happen, So as is being discussed today, we'll continue the important work to make sure all the sexual health clinics are accessible to people with disabilities. So just to add to that, that there are current barriers that are preventing us with the expansion. So while we support expanding medication abortion, we do have some concerns regarding cost, capacity, and clinic space.
Got it, okay. And does DOHMH have sufficient medication supply? If it were to expand to all 6 clinics?
So we currently do not, so we would have to
Okay.
reassess that as well.
And you said cost, capacity, and
Clinic space.
clinic space, okay.
Is critical.
Good to know, yeah. Are your agencies tracking disparities in health outcomes for people with disabilities?
We don't currently track disabilities.
The same for the health department. We do not currently track disability.
Would you consider doing so?
Sorry, just give me one second.
I mean, I would take it back to my site and it would have to go through.
You got it.
So right now, we do not have a way to classify individuals as having a disability. So we do not track the information for people who are coming to our clinics.
And could you elaborate on what that means, the classifying a person with disability?
From our standpoint, there are so many different types of disabilities, and it would really encompass a wide array of things, including vision, hearing, mobility, intellectual. I mean, it's a very wide open area or arena.
So similarly, since disability can be an important factor in understanding a person's health needs, it encompasses a wide range of conditions which may or may not be visible or disclosed by individuals. Given the complexity of defining and consistently capturing disability status across programs, the health department does not routinely collect comprehensive disability data for all services.
Got it. Again, coming back to the stat that 1 in 6 New Yorkers live with a disability, I think it's tremendously important we figure this out. I don't want to keep you much longer. I will ask my final questions. For Councilmember Gutierrez's bill on the doula Bill of Rights, is there currently an advisory body or other advisory component of the citywide doula initiative or newborn home visiting program? And how does it function?
For the health department, for the CDI, there are no advisory bodies. However, CDI staff work closely with CBOs to understand the needs of the community and challenges to expanding access. Insights received as part of our community engagement informs recommendations listed to our annual doula report, and we will be happy to discuss this latest recommendation with council once the annual doula report is released at the end of the month.
Excellent. I know I asked DOHMH about fertility treatment, education. Does H&H provide any materials on fertility care? Or have available, rather?
When patients come in with certain health conditions and discuss it with their clinician, they do receive a discharge summary that goes along with what was discussed.
Got it. And so does that mean that if I'm having a conversation about fertility treatment with my doctor, that H&H has produced?
We don't have pre-produced information on that.
Okay. And then what about just generally? How is H&H providing information about fertility treatment and options?
If someone came in and had a hormonal issue or other medical condition that needed to be treated, we would certainly be able to draw the appropriate lab tests and be able to rectify certain parts of infertility, but again, we don't provide any of the like in vitro fertilization or any of the procedural things are not provided. And so certainly a clinician can go over what those procedures are about, and our EMR, or our electronic medical record, has the ability to go in from the provider view, cover different topics, and then print them out for the patient and give it to the patient.
Does H&H have plans to offer fertility treatment?
H&H does not have plans to offer fertility treatment.
And then just from both of you as doctors, what are you seeing as the largest barriers to accessing fertility treatment?
One word: cost.
And so currently, there is no formalized guidance on navigating insurance coverage for reproductive health care, fertility care that each of the agencies may have in like a pamphlet.
That's correct.
Okay. Okay. Understood. Okay, I'm going to do one final review, and if you will just be patient with me for a minute. Okay. How does H&H ensure real-time communication accommodations such as ASL interpreters, CART captioning, and AAC devices are available for reproductive health encounters, including prenatal visits, labor and delivery, and postpartum care?
So we have CART services available. We also have, again, American Sign Language interpreters available, and they're available 24 hours, 7 days a week. We have language access coordinators at each site that are responsible for being the liaison between the patients, between the interpreters, and any departments that may be requesting an interpreter.
Excellent. And is the ASL through video or in person?
We offer both.
Both. And for DOHMH, around young people with disabilities. They are more likely to have a parent or caregiver present throughout their visits, which suppresses private, patient-centered conversations about sexual health. Do the sexual health clinics have an explicit protocol for offering all patients 12 and older confidential one-on-one time with the provider consistent with the clinic's stated policy of serving anyone 12 and over?
Yes, you would do. Well, we assess that at the beginning through the greeter and also during triage and assess and inform the parent that they will wait in a waiting area for confidential services for that individual within that clinical space with the provider.
Excellent. Well, thank you, Doctors Mendez, Wilcox, and Joaquin, and I heard Mandy.
Yes.
Sweet, and really, really grateful again for your service and just your the depth of knowledge shared today, and I look forward to continuing our partnership. Thank you so much.
Thank you.
Take care. I now open the hearing for public testimony. I want to remind members of the public that this is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant-at-Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant-at-Arms and wait to be recognized. When recognized, you will have 3 minutes to speak on today's oversight topic. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant-at-Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. Tracy Moreno. You can begin whenever you're ready.
Thank you. Good morning. My name is Tracy Moreno, and I'm a legal intern with the Disability Justice Program at New York Lawyers for the Public Interest. For 50 years, NOPI has worked alongside people with disabilities to remove barriers to equal opportunity and enforce disability rights. NOPI strongly supports Intro 941, requiring the Department of Health and Mental Hygiene to develop and offer resources, clinical guidance, and training on disability and accessibility in healthcare settings. While federal, state, and local laws require healthcare providers to provide equal access to patients with disabilities, legal protections alone are not enough. Too many New Yorkers continue to encounter providers who lack the training necessary to effectively communicate with patients with disabilities, understand their legal obligations, or provide appropriate accommodations. One of the most persistent barriers identified through NILPI's advocacy is the lack of disability competency among healthcare providers. Research has shown that many providers receive little or no formal education regarding disability accessibility, communication, or best practices for caring with patients with disabilities. As a result, patients may experience delayed care, incomplete examinations, inadequate accommodations, and poorer health outcomes. These experiences not only affect the quality of care patients receive, but also erode the trust in the healthcare system. Intro 941 directly addresses this long-standing barrier by providing healthcare professionals with the tools they need to better understand disability accessibility, communicate effectively with patients, and deliver more equitable, patient-centered care. Better training will not eliminate every barrier people with disabilities face, but it is an important and necessary step towards improving healthcare access throughout New York City. NOPI respectfully urges the Council to pass Intro 941. We appreciate the Council's continued commitment to advancing disability rights and health equity, and we look forward to continuing to work together to ensure that every New Yorker can access quality health care with dignity, independence, and equal opportunity. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. I do have a question for you. I'd like to understand what NILPI defines as disability competency.
We would say it's healthcare providers knowing how to care for, speak with, and provide information to patients with disabilities.
And you're saying that NILPI's work with some of its clients has indicated or exposed the lack of disability competency.
Yes, and through research as well.
And through research. Could you talk a little bit more about what those incompetencies are?
Like I mentioned, it seems to be a lot with the attitudinal barriers that they have. A lot of doctors don't think that people with disabilities will want many different things. They also won't have the accommodations proper, like we talked about extensively today. They won't have scales for patients to be able to use, and we think that goes along with competency.
In terms of the cultural piece, which I think is just so important and absolutely true, I remember in college, I used to receive disability services from the campus's program, and I used to get time and a half for exams. And when I explained that to one professor, he just totally dismissed that I needed that service. And that is a cultural, reaction, thinking that because I look able-bodied, that I must be able to complete whatever exam or assignment according to what he thinks, and not what I need. In terms of attitude changes and cultural shifts, what would NILPI recommend for healthcare workers? From what we heard about the various trainings that are offered, which, I think to me showed that there are various trainings, but they're not all interlinked in any way or coordinated. What would you say would help in the changes, specifically regarding culture?
I don't feel comfortable speaking on behalf of NILPI on that today. Well, I can speak, and we can get back to you on that.
That would be great, because I think the trainings, as important as they are, our definition of disability justice as a city needs to be, I think, more prominent, which is why I'd asked each agency about their definition in order to see one, whether they have a definition of disability justice, and then two, if that is agency-wide, being internalized for practitioners to then be able to change their internal biases on disability. Is there anything else you'd like to share that I haven't asked?
No, thank you.
Thank you.
Thank you so much.
I will now move to Zoom. Please wait for your name to be called to testify and select unmute when prompted. Brittany Misk or Miskey, apologies.
You may begin.
Good morning, and I do apologize as I had a technical issue with submitting my testimony, so I may be on your list twice, so feel free to remove me from the second time. But good morning, council members. Thank you for the opportunity to provide testimony today in support of Introduction 941. My name is Brittany Miskey. I am a white female with brown curly hair. I am wearing glasses and a purple pinstripe collared shirt with a navy blue blazer and navy slacks. I am a nurse practitioner by trade and serve as Vice President of Healthcare Management and Quality Officer for Care Design New York, a New York State care coordination health home serving individuals with intellectual and developmental disabilities across the state, operating under the auspices of Office for People with Developmental Disabilities, or OPWDD, and the Department of Health. In this role, I have the privilege of working alongside care coordination teams, community-based providers, healthcare partners, individuals, and families to improve access to service, strengthen advocacy efforts, and support better health and quality of life outcomes for people with intellectual and developmental disabilities. Throughout my testimony today, I will primarily focus on individuals with intellectual and developmental disabilities, whom I will refer to as individuals with IDD. The Introduction 941 would require the New York City Department of Health and Mental Hygiene to develop and offer resources, clinical guidance, and training on disability and accessibility in healthcare settings for clinicians. This legislation represents an important step and opportunity in the broader effort to improve access to high-quality, accessible healthcare services for individuals with IDD in New York State, particularly because the unique needs and experiences of individuals with IDD are too often overlooked in the development of disability education and clinical training. As a nurse practitioner who was educated, trained, and practices in New York State, I can attest that the formal training related to IDD is minimal at best. More broadly, education about disability, accessibility, communication needs, and the lived experiences of disabled individuals is often limited across health professional training programs, leaving many clinicians without the foundational knowledge needed to provide inclusive, person-centered care. In my own experience, my formal training consisted of little more than a brief lecture referencing conditions such as Down syndrome in the context of prenatal genetic screening. Important topics such as communication accommodations, person-first language, and adapting care to meet individual needs were largely learned informally through clinical practice and trial and error, rather than structured education. This is a common experience, and as a result, many clinicians are left insufficiently prepared to care for people with IDD across the lifespan. Individuals with disabilities are not limited to one specialty, setting, region, or socioeconomic group.
Time expired.
Every clinician...
You can keep going.
Thank you. I appreciate that, Council. Every clinician, regardless of practice area, will care for individuals with a disability at some point in their career. This is especially important for individuals with IDD who may be at increased risk for chronic and co-occurring health conditions. They may also experience delays in preventive healthcare screenings and cancer and late diagnosis of cancer when care is not accessible or communication needs are unmet. Without accessible, standardized training and practical clinical guidance, many providers are left to seek out this knowledge on their own, which contributes to inconsistent care and poorer health outcomes for individuals with IDD. Passing Introduction 941 would require the Department of Health and Mental Hygiene to develop these resources and standardized guidance. This is also an important step towards improving health equity and health outcomes for individuals with IDD, so they receive the high quality care they deserve. Thank you for letting me go over time. I appreciate it, and I appreciate the Council's consideration of Introduction 941 and commitment to improving access to high quality care. I'm happy to answer any questions the Council may have.
Okay, excellent. Thank you. I would like to know how the coordination works with families. How are you all assisting individuals? Where are they learning about care design?
So care design individuals typically learn about through other members of the community or when they go to obtain OPWDD waiver services. So typically when they go to get OPWDD waiver services, so think of DayHab, ResHab, ComHab, non-clinical services, they're provided with 2 to 3 options for a care coordination health home to pick from.
Got it. And then how does care design exactly like provide the service or recommendation? I'd like to just understand why care design is important.
Sure. What care design strives to do is advocate when we're seeing trends in lack of access or minimal access to care, whether it's due to provider education, accessibility, and also work to build relationships with our service providers and clinical providers in the community to explain, yes, we do have an individual with intellectual and developmental disabilities, but that bias that they may carry with them or you may see does not define them. And here's how we can overcome that barrier or challenge so they can get, for instance, a mammogram for breast cancer screening, or they can have colon cancer screening, or as we spoke about earlier, they may be sexually active. And saying such require those preventive healthcare screenings to assure that they are receiving support in early diagnosis and treatment.
And then what kind of, or what specific areas are you seeing most in need for advocacy when it comes to patient care?
At this time, we are seeing continued barriers for preventive care. The idea that an individual with intellectual and developmental disabilities may not qualify or require preventive care screening because there is a bias that they have a poor quality of life. And overcoming that barrier and providing education as to what an earlier diagnosis of these chronic diseases can mean for someone with IDD, just like it is for someone in the general population. Additionally, the diagnostic overshadowing of IDD follows folks and can often mask a diagnosis of mental health. And we have seen a lot of barriers in ensuring individuals receive a mental health diagnosis and then receive appropriate services to support that diagnosis, whether it be medication management, therapy, etc.
And what age group does care design work with?
I believe our youngest member right now is 4 years of age, and we manage our reproductive care coordination through the lifespan. So I believe our oldest member is 101, but don't quote me on that. She just had a birthday.
Well, happy birthday. Yeah. All right, thank you. Really appreciate it.
Thank you for your time.
I'd now like to call Ramona Ferreira.
You may begin.
Good afternoon, everyone. My name is Ramona Ferreira. My name is Guatuke Ini Inaru, and my colonial name is Ramona Ferreira. I am the founder of Safe Section 9. Safe Section 9 is a tenant-led coalition that works to educate and activate public housing tenants. And we tackle policies rooted in colonialism that have led to discriminatory disinvestment in America's only truly affordable housing stock. I am testifying today on behalf of myself as someone that lives with a disability, our members and neighbors throughout public housing. We want to amplify the importance of providing accessible, equitable services for folks with various abilities and remind you that 43% of households in public housing include a person with a disability. That's 21 points above representation in the city overall. So disability justice matters to those of us in public housing. We want to express our support for the really lengthy list of introductions and resolutions that you guys are looking at today. And we also want to highlight that the most stabilizing factor in our lives as people with disabilities is our home. We are a community living on fixed income and needing accommodations for mental and physical challenges. And NYCHA provides this, but it must be invested in to ensure that we are safe in our homes. This is why we are opposing Zoran's proposed budget for public housing. His proposed budget is the largest transfer of public monies and assets in recent history, and it will destroy the only truly affordable housing we have in New York City. That includes empowerment, economic support, social service resources, and front offices that know how to support us and have to support us in a specific way because of the federal mandates for public housing. The Committee on Disabilities should recognize that Section 9 public housing is one of the most important housing resources available to disabled New Yorkers. For many residents with disabilities, public housing is not simply affordable housing. It is the difference between housing stability and homelessness. Unlike much of the private rental market, Section 9 provides robust legal protections that allow disabled tenants to request reasonable accommodations necessary to fully use and enjoy their homes. And these protections include unit modifications, accessibility improvements, assistance animals, transfer requests, live-in aids, and policy adjustments that support independent living. Disabled New Yorkers face extraordinary barriers in the private housing market. Many of us rely on fixed income through SSI or SSDI, making market rate housing unattainable. We also face widespread discrimination, a severe shortage of accessible apartments, and significant challenges navigating the rental market. The economics are stark.
Time expired.
A national analysis.
You can keep going.
I'll end by saying that a national analysis found that an individual relying on the average SSI benefit could afford virtually nothing beyond rent after paying the fair market rent for a modest studio apartment. Without public housing and other housing assistance programs, many disabled New Yorkers will be pushed into housing instability or homelessness. And I want to mention our one of our leaders, Teresa Scott. She was a Black woman who was wheelchair ridden and a strong advocate for Black maternal health. And it would be just wrong if I didn't mention how she personally brought to our group the awareness of the challenges for folks needing a lot of the infrastructure that you've been discussing today. And she was actually from Far Rockaway. So it was really sad to hear that things haven't improved for women like her in her community. Thank you.
Thank you so much, Ramona, for your testimony and emphasizing the importance of housing stability and housing accessibility as important factors to the conversation that we were having today. And we really look forward to examining public housing and accessibility and the healthcare disabilities that you've mentioned in your own lived experience as one of our future hearing topics. We really, really appreciate your advocacy for Section 9 housing. Thank you.
Thank you.
Kimberly J. Combs.
You may begin.
Okay, and then back TM.
You may begin.
Okay, thank you to everyone who has testified. If there is anyone present in the room or the Zoom that hasn't had the opportunity to testify, please raise your hand. Okay, Mbake TM. Apologies for mispronouncing your name.
You may begin.
Hello, Hello, can you hear me?
Yes.
Thank you. So I was trying to unmute, but it wasn't letting me speak. My name is Micah Cham. I'm the Housing and Health Community Organizer at the Center for Independence of the Disabled, New York. We advocate for people with disabilities in the 5 boroughs of New York City. And I want to take a moment and thank the chair of the Disabilities Committee, Chair Hanif, because this is very important to us. Right now, I know I only have 2 minutes, so I'm not going to dig into the details regarding the challenges that people with disabilities change regarding reproductive justice. And but I will submit a written testimony. I just want to highlight that all this starts from fertility issues until having the baby, going down to keeping it up with all the appointment with the healthcare provider, and I will draft a written testimony and submit it hopefully tomorrow or so. Thank you.
Thank you so much for your testimony. Seeing no one else, I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the close of this hearing by emailing it to testimony@council.nyc.gov.